EMR has now become the preferred initial treatment modality for large colonic polyps or any colonic polyps, and with good reason. It's got low complication rates, and compared to surgery, there's low morbidity. Um, However, recurrence rates have been variable, and in Western studies that have been published, even recurrence rates of up to 40% have been reported. ESD, we all know, was developed in Japan for the treatment of gastric cancer. We're all aware of its benefits and drawbacks, the benefits mainly being on-block resection rates and resultant very high cure rates. But there are the drawbacks of the long learning curve and higher complications. And speaking of complications, this was a large series of more than 1,000 colorectal ESDs performed in Japan, which showed complication rates of 6.8% and perforation rates of about 5%. Compare this with this a French study that was published that showed complication rates of about 30% and perforation rates of 18%. So there is a disparity between Japanese and Western endoscopists while performing ESD. But I'd just like to show the technique of knife-assisted resection, which combines the principles of both EMR and ESD. On the left is a flat dam in a colitic bowel, which was difficult to lift. And on the right is an anorectal recurrence after TEMS, very fibrosed. In both these lesions, an endoscopic knife is first used to make an incision around the lesion, and this is followed by a limited submucosal dissection, about 1 centimeter, and the aim is to create a groove in which the snare can engage safely. And the tumor has shrunk down because of the submucosal dissection, and after this, the snare can safely engage around the lesion, and the lesion can then be removed either en bloc or piecemeal, depending on the size of the resultant lesion. So we aim to look at whether this technique was feasible to be used in clinical practice, and what would be the outcomes of this technique, and what predictors, what factors, if any, predicted these outcomes. So as with the cohort study of patients all referred to us for difficult colonic polyps between 2007 to 14, and there were 170 polyps in an equal number of patients. And when I say difficult, so these weren't small polyps, they were large, of mean size of 46 millimeters. The minimum size was 20, and they were going up to even 170 millimeters. There were a few adenocarcinomas, and there were a few dams which are difficult to resect. And all the